Let's move on to talk about the next general category of injuries that we want to be able to identify and modify. Chest injuries. What we're going to do in this block is we're going to talk about how to treat an open chest injury. Very importantly, and if you learn nothing else from this block, I promise that you will remember this. When we identify somebody has an open chest injury and we correctly treat it by placing an occlusive dressing, we are obligated at all times to continue to monitor the patient for the development of this life-threatening complication called a tension pneumothorax. I promise you we're going to hear this a dozen times before we're done. After we treat an open chest injury, we're going to continue to be aware of the potential for development of the tension pneumothorax, and we're going to review how we treat a tension pneumothorax by applying a chest needle decompression. I have to give you a little bit of anatomy and physiology so that the injuries make sense to you. In precision rifle craft, we have an old saying, amateurs study ballistics, masters study the wind. What does that mean? It means it's fairly amateurish for somebody to argue about the ballistic superiority of one round versus another. How much drop a round has at any given range is deterministic. It's repeatable. We understand it, we apply corrections, it's no big deal. It's something we can control. What we can't control is the wind. And master riflemen spend a lifetime studying the wind. It's the variable we can't control, and it's what we have to learn to read and adjust for to be able to hit our target. The corollary to that in medicine is simply this. Amateurs study anatomy. Masters study physiology. It's not that anatomy is not important. It's the basic language that we all need to be able to communicate. But to actually understand what is going on in the body and the things that we can't necessarily control that are not always deterministic and repeatable, we need to study physiology. Essentially, air goes into your lungs either from your nose or your mouth, and they take the passage down your airway into your lungs. Your chest contains two lungs with the heart in the middle. One thing I want you to notice on the image, the heart is not a particularly left-sided structure. It is a very central structure right behind your sternum, your breastbone, and a portion of the heart, the large pumping part of the heart called the left ventricle, does tend to be slightly more to the left than in the center. But your heart is in the dead center of your chest, essentially between your nipples. The diaphragm, or the fajita meat, is this big layer of muscle that separates your chest from your abdomen. It helps us breathe. You have muscles between the ribs called the internal and external intercostals. You have the diaphragm, and you have other accessory muscles around your neck that all aid to help you expand your rib cage to breathe in and then relax to let you breathe out. So to understand how this anatomy gets disturbed, we have to talk a little bit more about physiology. But first, what constitutes a chest wound? This is an open chest wound. This is somebody lying on their back, their head is to your left. The doctor has peeled back the occlusive chest dressing, and what you're seeing is a hole in this person's anterior chest. What you see moving inside them is lung tissue and the heart. This is the definition of an open chest wound. Let's go back now and spend a second talking about the physiology of how you breathe. You have to realize that breathing is a fairly passive process. What do I mean by that? You don't suck air into your lungs. What happens is your body creates a state of negative pressure inside your lungs that allows the higher pressure ambient air to enter your airway and make its way down into your lungs. What happens is there is a very thin film of tissue that surrounds your lungs that essentially makes your lungs airtight. And then there is a parallel reflection of that same tissue on the inside of the chest wall. This lining is called the pleura. The layer of pleura that lays on your lungs is called the visceral pleura. The layer of pleura that is inside the chest wall is called the parietal pleura. How does this help us understand a chest wound? It's very simple. What happens is there is a very thin layer of fluid that lies between the pleura in what we call the interpleural space. That fluid serves to create surface tension between these two layers of pleura. Imagine, if you will, how you breathe. You don't think about it, it just happens. Mechanically, here's how it happens. Your muscles work to expand your rib cage. The pleura pulls the lungs open and expands them inside your chest. When that happens, that negative pressure inside the lungs is created and air rushes into your lungs by this passive process. We do the opposite when we're exhaling. Some muscles contract, some muscles relax. The rib cage contracts and air rushes out of the mouth. You can use your abdominals or your diaphragm to force air out of your lungs, but you can't force air into your lungs by yourself. This is a process that happens solely because of this interpleural space, the space between the two layers of pleura remaining intact to allow the lungs to inflate and expand as you expand your chest wall. Clear as mud? We talked a little bit about how anatomy and physiology knowledge makes us better at our job as operators. Here's one way this is going to help you. When the man said, "Let blood out and let air in," he was talking about chest injuries. When the interpleural space becomes violated, we have done something very significant to interrupt somebody's ability to expand the lung, to exchange oxygen with the blood, and that is one of the primary ways we cause shock in a person. I want to draw your attention to this image. This is a basic diagram that will give you a visual idea of what an open chest injury looks like. And now you'll be able to understand why that happens. In general terms, it takes a hole about the size of a nickel in the chest wall to produce an open chest injury. What's happening where the bullet or the missile penetrates the chest, besides the direct damage that it is doing to the tissues, including the lung, it is interrupting the interpleural space. It's letting air come in. When that space is violated, you can't create negative pressure in that lung to draw air into the lung. We call that state euphemistically a collapsed lung. That's a euphemism. I've spent years doing thoracic spine surgery and thoracoscopic surgery, and I can assure you that those lungs are in my way almost the entire time of surgery. Anybody who's a hunter, and people who hunt have a big leg up on everybody else in understanding these things, all of us know that the lungs are relatively solid organs. When you give somebody an open chest injury or you enter the interpleural space, the lung doesn't collapse up into a little raisin. It's a solid organ. It is still there. When we say collapsed lung, that's a euphemism. It simply means that the lung is not expanding to its full capacity. Air is communicating from the outside world into that interpleural space. You can't expand the lung, and it greatly decreases your ability to oxygenate your blood. Leaving the chest wound open and not covering it won't help the person breathe better, but it's a condition where they will not develop tension. Stay with me. This will all make sense in a minute. The other aspect to an open chest injury is not just air entering from the outside world to the inside of somebody's chest. They have a condition that we call an air leak. What does this mean? Air travels from our upper airway through our trachea down into our lungs. When a missile has penetrated the lung tissue itself, it has also disrupted the visceral pleura, that lining directly over the lungs, and it has violated the lung and the tiny airways within the lung itself. Every time somebody breathes in, even though the lung is collapsed, some of that air passes from the small airways and the lung tissue and gets trapped within the chest. If the person has an open chest wound, that air can escape by the same hole where air is entering the chest cavity. It will become obvious in a few minutes why this is important to understand. Let's talk about the simple case, somebody who has an open chest injury. What can we do to aid their ability to breathe successfully, to keep oxygenated blood, and to try and keep them from going into shock? We can aid them by applying an occlusive chest dressing. What does occlusive mean? It means it's something like plastic. It's something that air won't pass through. And what we'll show you in a minute is how you can make an improvised chest dressing or how you can use a prefabricated chest dressing to apply an occlusive seal to a chest defect. Obviously, we need to apply it to wherever there is a defect in the chest. And very frequently, if there is an entrance side to the chest, there's usually an exit side. And we have to find every defect and make that defect occlusive with a dressing. All right, this stage in Combat Lifesaver, let's start talking about how we're going to treat that open chest injury. The basics again are the interpleural space has been violated. The lung tissue itself has likely been violated. The person can't expand their chest effectively and expand the lung with it to inflate the lung and get good oxygen. How can we help that person? We can help them by helping to reestablish an airtight environment of the chest so that when they expand the chest to breathe in, they're going to develop better negative pressure and fill that lung. The basic way we do that is by making or using a prefabricated occlusive chest dressing. What does the word occlusive mean? It means that air won't pass through it. Generally, a piece of plastic will do the job. It might be something as simple as the cover for the trauma dressing that you've saved after you have to put a battle dressing on them. If you can't blow through it, generally it's occlusive. You could use this as a field expedient dressing to cover an open chest wound. But we can do a little bit better than that. Other forms of expedient dressings take the form of what's called Vaseline impregnated gauze. This is the same material that I use in the operating room or the hospital to seal a chest tube because it is occlusive. It is cheap. It costs pennies. The foil package that this comes in is damn near bomb-proof. I have Vaseline impregnated gauze in foil packs folded up in IFACs in rigs that have stayed that way for 3 years in all kinds of weather conditions. When I've taken them out and re-examined them recently, we're still good to go. Vaseline impregnated gauze is nothing more than Z-folded gauze loaded with Vaseline. Vaseline helps to form an airtight seal, and it is particularly occlusive. How do we apply an occlusive dressing, be it Vaseline impregnated gauze or a piece of plastic, to make a field expedient chest dressing? Very easy. Imagine anywhere on this side of ribs that there is an open defect, just like you saw in the video. Same thing, just like applying a battle dressing. Take the center of the occlusive dressing and apply it over the center of the defect. Now we have to secure it. We need to secure it with tape. What kind of tape? What size of tape? Thin tape is not going to do. It is not going to let you form an occlusive seal, and it's also not going to keep the dressing in place. You need to have tape that is at least 3 inches wide, if not 4 inches wide, and has properties that allow it to stick to skin. Mike and I each use and provide combat rolled duct tape. It does an excellent job. This is surgical tape, cloth impregnated surgical tape, which does an especially good job of sticking to skin. However, if the skin is dirty, if the skin is sweaty, if the skin is bloody, no tape is going to effectively stick to it. So at this point, after you've applied your dressing, you have to do something to clean the skin so that the adhesive will stick to the skin and let the dressing stay in place. Mike, do you want to assist me? Let's use some combat rolled duct tape. Be generous with the tape. There is no reason to be stingy and try and make it look like an art project. Cover the dressing and make sure you have enough tape that's going to stick to the skin. My recommendation is to apply about 50% of the tape to the edge of the dressing on the side that you're applying it, so that the other 50% of the tape is available to contact the skin. You're going to seal this dressing on all 4 sides. Many of us who are old enough were once taught that you should only seal an occlusive chest dressing on 3 sides. The idea being that if you left one side of the dressing open, hopefully any air from a tension pneumothorax would be able to escape through that unsealed 4th side, and it was even taught that sealing a dressing on 4 sides was what was going to cause a tension pneumothorax. That doctrine is completely false. It was false at the time, it is false now. There is no evidence that a 3-sided dressing will prevent a tension pneumothorax from occurring. There is no evidence that it is superior in any way to a 4-sided dressing, and the recommendation is occlusive dressings be applied with all 4 sides secured. It's necessary to seal as many defects as exist. Very frequently, if there is an entrance wound on one side of the chest, there's going to be an exit wound on the other side of the chest. You have to examine the back, you have to examine the entire chest and look for any further defects. If you only seal one of the defects and there are more, you are not going to help the patient improve their respirations in any way, shape, or form. How to make and apply a field expedient chest dressing is a necessary skill, but we can do better. There are many types of prefabricated chest dressings that work equally well or actually better because they're easier to use. The Committee on Tactical Combat Casualty Care generally does not favor or recommend one product over another. What they very wisely do is recommend features that a product should have. I don't have any dog in the fight. There are many makes of prefabricated chest seals. I happen to prefer the Halo. That's what I carry, and that's what I issue to people in our classes. It contains 2 prefabricated chest seals to seal an entrance and exit wound. It's in an external package that is extremely durable, and likewise, I have several of these in IFACs that have been folded into thirds that when I've pulled them out recently to re-examine them, the external package is completely intact. That is a desirable feature. The chest seals itself are extremely simple to use. The Halo contains 2 chest seals. They're translucent and they're great dressings because you can see the wound through the dressing. It's particularly simple to apply. You simply peel it off of its backing and in the same manner locate the center of the wound and place the center of the dressing over the center of the wound. It will seal circumferentially around the skin. In the same manner, nothing will stick to sweaty, dirty, bloody skin. You have to take that extra second to dry the skin before you apply the dressing, whether it's a prefabricated or whether it's a field expedient. What happens now after we've applied the chest dressing and we've aided the person by making an occlusive dressing? There's something else that we can do to aid their respirations, and it's simply this. Let that person assume whatever position of comfort they can assume, including sitting up. If the situation permits, let the person sit up. Get them into a sitting position where they're back against the wall. Let them bend their knees, place their arms in their lap. They can prop themselves up, and it creates the same effect that a large animal has to create in themselves by being upright. When you're laying down, the weight of your body restricts your breathing. Being upright and allowing gravity to assist you breathe aids respirations greatly. If a person wants to assume a sitting position and it is tactically permissible, let them and assist them get into a sitting position. If a casualty feels that it would aid his breathing to sit up and the tactical situation permits, assist him sitting up. You can get his back against some kind of hard cover, get him into that position, loosely cross his ankles, let him keep his hands in his lap. This will allow him to sit forward. It'll keep pressure off his chest, make it easier for him to breathe. If he's going to vomit or he has secretions, he's just going to do it in his lap and he's not going to aspirate. Again, if the tactical situation permits, getting a casualty into a sitting position will aid his respirations greatly.